Hi, I'm Gianna Boveri, and today I'm going to tell you about the health belief model using two behaviors: safe sex and risk taking, and condom use. So, a little background on the HBM, the health belief model. It was created in the 1950s by sociologists who were wondering why tuberculosis vaccinations, though accessible to the community by vans, were not being utilized. So, they created the health belief model to examine why they were. So they wanted to understand the widespread failure of people to accept disease preventatives or screening tests for the early detection of asymptomatic disease. And the model helps us see how individuals perceive health threats and decide to act based on the value individuals place on particular goal and the likelihood that actions taken toward the goal will be successful in achieving it. And the health belief model tells us that mental processes inform behavior. So, within the context of this discussion, health educators might ask, how do health beliefs and perceptions inform sexual risk taking and condom use? So, the importance to us as health educators with sexual risk taking, we want to define it first. So, behaviors that could lead to unintended pregnancies or sexually transmitted infections. Some behavior examples of this are frequency of STI testing, number of partners, and relationships to partners that they choose to have intimate experiences with, contraception use, so barriers or hormonal methods, etc., use of substances during sex, so drugs or alcohol, using only contraception for intercourse and no protection for oral sex or anal sex. And some potential causes that we're going to discuss a little later are high trust in their community, high partner trust, and lack of sex education. So, us as health educators looking at sexual risk taking as an unwanted behavior, how do we impact these beliefs and perceptions to create behavior change? So, here's a short clip before we talk about condoms. I will provide a link to this video in the comments as it's not letting me present, but please watch until 1:24. Condoms prevent the spread of STIs and pregnancy. Individuals will choose to use condoms based on beliefs, availability, and knowledge. So we can see in the video that condom use is not as widespread as we would like to see as health educators. And using the HBM, we want to examine the beliefs that impact the likelihood to use condoms, even if they are available or if they already have the knowledge. And as health educators, it's a powerful prevention tool if the materials and education is properly provided. Now we're going to talk about the health belief model's constructs, and then we'll get into some articles that relate the behavior to the model. So first we have perceived susceptibility. This is an individual subjective assessment of their risk of developing a health problem, their own belief of how likely they are to develop an ailment or a specific problem. Do they think they're at risk? So someone with high susceptibility for chlamydia would be believing that there's a high prevalence of chlamydia in their community and they're likely to get it if they make certain health choices. Perceived benefits, so this is weighing costs and benefits, deemed advantages or gains of a health behavior. Does the individual believe this health behavior will lead to a positive outcome? Self-efficacy, how confident one feels in their own ability to practice a health behavior. Do they feel confident they can successfully execute the behavior? So for example, does someone believe that they can enter a sexual situation and have the conversation of how many partners have you had? Have you been tested recently? Do they have the self-belief that they will go forth with bringing out a condom and using it properly? Perceived severity, how harmful one believes a disease or condition is and the potential harm if left untreated. So does the individual believe the consequences are serious? Does someone think having an STD is a serious consequence, or do they feel that it's something they could deal with? Perceived barriers, obstacles that would impede a health behavior. So what obstacles might prevent a health behavior from changing or occurring, or what do they think those obstacles are? If they can't get contraception because of the distance and they feel they can't get there, something that might mitigate that perception is telling them about a bus line that goes there. Cues to action, triggers, circumstances, or stimuli that incite a health behavior. What might cause a health behavior to happen? For a certain health behavior, what catalyst might set that into action? So for our first article, we're going to talk about this article, Toward an Understanding of Barriers to Condom Use in Rural Benin Using the Health Belief Model, a cross-sectional survey. The purpose of this survey was to identify barriers to condom use using the health belief model in Benin, West Africa. So they had 235 participants from Benin, 155 men, 80 women. There was a little over 50% Christians in this study, which makes sense for this population, perhaps, but the external validity might not be there for that. 48.5% were married in monogamous relationships, 20% were married in polygamous relationships, and 35% were single or widowed. They used a cross-sectional survey, and they did interviews with a structured questionnaire, and they used a logistic regression to identify factors associated with condom use. So the findings told us that there is a more likelihood for them to use condoms if they have a good and high perceived quality and perceived efficacy of it. And then we see that high perceived risk and perceived severity among all participants. The women in the study had higher than men, and this information does not inform or encourage condom use. So 63% had low perceived efficacy of condoms to protect from HIV. In other words, they did believe the condoms could inhibit contraction of HIV. And 88% of participants had problems using condoms, according to the interviews. Recommendations from this survey: using it for designing and planning health intervention programs, using it to inform resource allocation, using it to go ahead and do further evaluation of condom outreach activities in Benin, community programs using problem-solving techniques created for target populations, and using behavioral communication strategies based on fear. So in this, they want to increase perceived severity. For our second study here, we have knowledge of AIDS, perceived risk of AIDS, and at-risk sexual behaviors among other adults. The purpose of this study was to identify older adults' knowledge of AIDS, assess their perception of personal risk of AIDS, and identify at-risk behaviors. So what they did was use a descriptive correlation design to survey participants, and the survey was created with the framework of the HBM. So the demographics of this population, there was 166 responses, all above the age of 50, 94% white, not a very diverse sample, 67% female, and 51% married. All completed high school or some level of higher education. And all participants utilize a university-based senior program. So the findings of this study, we see that condom use is low in this population, 17% always use, 9% sometimes use. They found that knowledge of AIDS and age have a negative relationship. So the older they are, the less knowledge they have. They knew basic facts, but they didn't know as much about transmission, cause, and medical aspects. Less education indicated less knowledge. Age was a predictor of knowledge, and the older the individual indicated less knowledge, like I said before, and they have low perceived threat. So recommendations for research: education is a major prevention tool for mitigating AIDS contraction. Additional research with more diverse samples, external validity is low. And to further examine older adults who are single, widowed, divorced, or separated, and assess at-risk behaviors who use safe sex practices. Recommendations for clinicians. So working to diminish the stigma against elder sexuality. This leads to a lack of testing. Seniors only make up 5% of HIV testing at government-funded sites, so perhaps integration of sexuality assessment into clinician protocols to become the norm. Elderly patients continue to go undiagnosed, as it is not the norm within the protocol and practice for this age group. Next, we have predictors of preventative behaviors of AIDS and HIV based on health belief model constructs in women with high-risk sexual behaviors. In other words, what beliefs or perceptions cause these people to practice preventative behaviors of HIV and AIDS, and they did this using constructs of the HBM. So they had several questionnaires that they implemented to 200 female sex workers ages 16 to 55. They're all referred to vulnerable women centers across Tabriz city and had multiple sexual partners. That's the inclusive criteria there. 19.5% of them were illiterate, and less than half of them were married. In the questionnaires, we have them looking for information on their socio-demographic characteristics, HIV knowledge, behavioral prevention on STIs. HBM constructs were used to look at self-efficacy for negotiating safe sex, perceived sensitivity, aka susceptibility, and severity, perceived barriers, and perceived benefits. They found significant correlation between behavioral prevention and high perceived sensitivity. There was a positive significant association with behavioral prevention with higher perceived severity, self-efficacy, perceived benefits, and HIV knowledge. The recommendations from this study tell us to use it to inform training programs, and they should be aimed on improving the health belief of HIV preventative behaviors, and aspects of this study to be used for midwifery, clinical services, health planning, and counseling. For our fourth article, we're going to be looking at hooking up and sexual risk-taking among college students, a health belief model perspective. This is what I think is the most interesting article that I found for this presentation. So if you look into anything further than this, I would recommend this article. So the purpose of this study was to explore college students' rationale for risk-taking during hookups using a theoretical framework from the health belief model. And in the article, a hookup is defined as kissing and fondling of the breasts or genitals, oral, anal, or vaginal sex. They used semi-structured interviews using a framework from the HBM, and they interviewed 71 college students ages 18 to 24, 39 men, 31 women. There is 84.5% of the participants were Christians, which I think might have biased the study a little bit, but it did make sense for the population. And there were only 3 LGBTQ participants. And to be part of this study, they had to have had at least one hookup. So the interviews, first one was assessment of sex and dating norms on campus. Number 2 was assessment of events during recent hookups, what happened. Number 3, assessment of evaluation of overall hookup experience, how did they feel about it. And number 4, assessing the perceptions of sexual risk-taking during the hookup with respect to STIs. And they used a microanalytic content analysis to identify key factors and themes from the interviews. So there's a lot of findings in this article. I'm going to try to go over a lot, but we definitely won't be hitting them all. So we can see that students show low perceived susceptibility. Most don't think they're at risk for STIs, especially during oral sex, with fewer than 5% expressing concern. Their perceived severity is also low, partly due to overtrust in partners and their community and inadequate education on STI risks. While students report high self-efficacy in their knowledge and intent to use condoms, their self-efficacy drops when it comes to planning or discussing protection, especially in situational contexts involving alcohol, sexual arousal, or coercion. These moments override intentions and weaken the link between knowledge and behavior. The students' perceptions of oral sex is very important. In this study, they don't necessarily perceive it as a sexual behavior that indicates sexual risk prevention. So when an interviewer asked a student, did you use protection? The student said no, because we didn't have sex. Interviewer said, so even with oral sex, you didn't use protection? And the student said, right. There were many recommendations in this study, and as someone who works with college students, I found this extremely helpful. Challenging taken for granted assumptions regarding susceptibility of partner and self. So using education focused on the contraction of STIs following oral sex specifically. Acknowledging perceived costs and benefits, so their present bias of using a condom, weighing benefits of pleasure over the costs of an STI, and using education to mitigate that. Increasing the availability and knowledge of contraception in students' daily proximity. They also suggested mandatory nationwide sexual risk prevention programs, and they argue against abstinence-only programs. They suggest creating programs informed by cultural and social context, so using social norms to inform how a study is created. They also suggest alcohol abuse and prevention, reducing instances of inhibition. So here's our last article, using the health belief model to predict safer sex intentions among adolescents. So they had a 43-item survey using an HBM framework, and we can see the constructs used here. The demographics of this population were 679 adolescents from 7th, 9th, and 11th grade in South Carolina in public schools. So they found a few things. First, they found that students' intentions to practice safer sex declined with age, which is interesting. In the first study, we discussed the elderly population, and in that study, they found that the older the people were, the less knowledge they had. So I wonder which generation has the best AIDS knowledge. The female students had higher intentions for abstinence and monogamy, so only having one partner and refraining from sex. The older students had more AIDS knowledge, but this had less influence on their behavior, and their knowledge did not strongly correlate to perceived susceptibility. The recommendations from this study are using modeling and social learning to affect health behavior change, reinforcing condom use as a social norm, and using education to reduce perceived barriers and increase perceived severity and susceptibility. So we have some overall takeaways from the articles. There were many, but I'm going to cover a few. Knowledge does not always indicate action of healthy behavior. So even if someone has knowledge on what STIs are, it doesn't necessarily indicate that they will practice safe sex behavior or use condoms. So some possible indicators for sexual risk-taking and or condom use are low perceived susceptibility, so they have high trust in their community or their partner that they will not have an STI, and low perceived benefits. The implications and recommendations for future use. Use cultural and social information of the population to inform methods, increase knowledge on perceived susceptibility, increase social norms of healthy sex behavior, and reduce perceived barriers. So which behavior works best with the HBM? I chose condom use. It's less broad than risky sexual behavior. There's a clear cost-benefit distinction. And how I would use it in application is for college students at the college that I work at. I would first assess the population for social and cultural norms to inform how we would create the questionnaire. Implement semi-structured interviews assessing perceived susceptibility and severity associated with STIs and perceived efficacy of condom use and where condoms are acquired. Use microanalytic content analysis to identify themes after interviews have been completed. And then I would use the information to inform a sexual wellness course for first-year students we have on our campus. I would use it to create a health fair with peer educators who would help create and implement. And I would increase the volume of contraceptives on campus and strategically place them based on the information we gathered. This is the end of the presentation. Thank you very much. And here are my references.